Hello, friends. Welcome to another CPS VMR Tuesday session. It's my pleasure to be co-discussing again with my great friend here, Keaton, and we have a great surprise. I was just talking with Sammy, a longtime CPS VMR member who's back from the rigors of training. He's actually brought a case to us, and it's such a delight to have him back and also have him present a case. So before we get underway, I'm going to swing the mic over to Sammy just to say hello. How are you, Sammy?
Hi everyone. Hi Ravi. Hi Kirtan. And it's so nice to be back. I'm Sammy. I'm a third year internal medicine resident in Austria, similar to Lea Bischoff. Maybe you know her. We're at the same university, and I was with CP Solas like from the beginning, like 8 years. I don't know when it got launched, and when I started residency, everything got so busy with science and education that I can't be active and participate. I wasn't able to be active in participation, but I still follow every VMR and stuff. And the last months have been thinking I have to come back sometime and relive this community, reactivate this community in my life. So yes, very glad to be here and even gladder to have Kirtan and Ravi discuss this case that I recently saw.
Perfect.
Wonderful. Yeah, what a surprise. And then I'll swing the mic over to Keaton to introduce
Yeah,
himself. Go ahead.
perfect. Thank you so much, Sammy and Dr. Singh. Yes, like I remember when I joined initially, like our members were very limited, like maybe 20 to 25 members, very closely knit community at that time. And Sammy was one of them. And we were like med students together, then we became residents together, right? Kind of like that. So it's so nostalgic to have Sammy back and always challenging cases. So let's see how much we can learn from Sammy's case. It would be great. And again, always a pleasure to discuss with Dr. Singh as well. So excited for that. And now I will swing the mic to Eugene, who is helping the teaching points. How are things going with you today, Eugene?
Hi, Ketan. Hi, Dr. Ravi. Hi, Sami. I think I've not met you yet, but I'm excited for your case. So I'm Eugene. I'm a physician here in Ghana, and it's been a wonderful week. I'm excited to be the teaching points today.
Perfect. And then Sarah is helping with the scribing. Sarah, how are things going?
Going well. I'm a fourth year medical student at Emory, and I'm excited to be here today.
Perfect. Thank you so much, Eugene and Sarah, for helping with the scribing and teaching points. And yeah, Sammy, we can get started whenever you are ready.
All right, then let's get this started. So this is a case I saw a few months ago. I do a lot of shifts in the ED and also in the emergency in the on the intensive care unit. And I first saw this patient in the emergency department. So this is the story of a 21-year-old female that presented with progressive diffuse muscle and joint pain, and especially in both hips, wrists, and ankles since 2 to 3 days. For review of systems, it's positive. During the same periods, she also experienced some odynophagia, sensation of being unable to fully open her mouth, and also said that she may have noticed a rash on the trunk and upper extremities. The review of system was negative for joint swelling, redness, dyspnea, chest pain, any chest pressure, hemoptysis, syncope, leg swelling, fever, chills, rhinorrhea, cough, dysuria, headache, or abdominal pain. Her bowel movements were normal and also her appetite was normal. So that's how she presented in the ED.
Keaton, I started the last time. I'll hand it over to you to start.
Thank you so much, Sammy, for a rocking start. So it looks like it's a young lady who is presenting with acute onset of symptoms, almost like fulminant, right? And what are the main symptoms we are seeing? We are seeing the rheumatologic symptoms, right? And when I use the word rheumatologic, I'm trying to refer to tendons, ligaments, muscles, joints, right? So that is what we are seeing, that this person has involvement of multiple joints or multiple maybe periarticular structures, right? Probably there is some degree of involvement of muscles as well. We are still not sure. And then something is on the skin. We have the rash going on. We have symptoms in the oral cavity as well. So we have like pain when there is swallowing. And also very interesting that patient has difficulty in opening the mouth. And we would characterize it better on the examination. that what do we mean when we say that there's difficulty in opening the mouth? Because classically, we mean that person has trismus, that when you are opening the mouth because of the fact that your masticator muscles or the muscles of mastication are somehow inflamed or somehow involved in some way, that is the reason why you are not able to open the mouth, right? So we will characterize that problem better, that what do we mean by not opening the mouth. Now, whenever you are dealing with such like complex scenario, then it's better to stick to the big picture rather than coming up with the each and every individual differences right away. So whenever something happens acutely and you have the involvement of rash and your musculoskeletal system, the equation is in a way kind of simple, that did something happen from outside? So is it an exogenous agent or is it the endogenous problem, right? What do you mean by exogenous problem? That you can have an acute viral infection which can trigger any of these scenarios. Any of the viruses can end up affecting your musculoskeletal system, can end up causing rash, can end up causing non-specific symptoms, right? Similarly, if you have any exposure in the form of maybe you took new medication, maybe you used any new drugs, maybe you used or received, let's say, any vaccines, or maybe you inhaled something. So any kind of exogenous exposure that you could imagine, any of them can trigger the immune system activation and can present in such multi-system presentation, right? So these are the two big exogenous things, infection versus exposures. Then let's say if you're not able to find anything there, or if you're not able to make progress through that angle, then you start wondering that what could be going on inside the body which did this, right? So from inside the body, you start thinking that, okay, maybe the immune system is activated. And then like you think about the big picture, that what arm of the immune system is activated? Is it your innate immune system which is activating, or is it your adaptive immune system which is activating? And this does help in making the progress, because just to lay down two classic examples, that this is a young person with acute onset of articular and cutaneous manifestation, you could think that can she have lupus? And we know that lupus is example of innate immune system, sorry, adaptive immune system activation, right? But on other hand, if Sammy tells us down the line that, oh, this person is having fevers continuously, and maybe there is something wrong with the liver, something wrong with the ferritin, and then you start thinking that, okay, could this be a case of Still's disease, which is example of the innate immune system, right? So these are the two broad arms of immune system which can end up causing such kind of symptoms. So that would be my big picture, to try to understand what is the exogenous exposure and what is the endogenous problem which could be causing all of this. I will pass the mic to Dr. Singh. What are his thoughts?
You give a wonderful overview of the conditions that could be at play here. I think it's kind of too early. This really has a pitfall of autoimmune phenomena, right? If you think about it, age, right? Epidemiologically, and then multi-system involvement, all the different linings and connective tissue, fascia, all kind of are in unison being affected. So I do like that you're also dwelling on what if this is a manifestation of infection. Infections, I mean, at this age range, what's common? I mean, bacterial, more viral than bacterial, and viruses can manifest in many different forms and involve many different tissues. The muscles are just very painful. The joints are inflamed. If you look at the joints, though, there's nothing there. It's just very, very painful. So this inflammation just heats up every tendon, ligament, every joint, and it is very painful. I myself have had a severe case of flu once, and I swear my joints were like, and my back was on fire. It was so painful. So what's interesting, if we have to sort of point our compass on anything, I'm very interested with this odonophagia, which is interesting. I wonder if this is a involvement of the esophagus or the surrounding structures. You talked about trismus. In young people, infections in this area. I would definitely like to do an exam and then exactly put my fingers around the jaw and the floor of the mouth and then look for lymph nodes. So certain viruses that may be predominant in this age range. So we think about EBV, CMV, and so on. How about looking at the tonsils, looking for strep throat and so on? And strep throat can induce multi-system inflammation if you think about it. And then if you think about autoimmune phenomena, you have muscle within the esophagus itself, and you could have pain, you could have trouble swallowing. So we need to get more data, but I think right now we're in the two domains, possibly infectious, possibly autoimmune. And I think more information, such as the exam, really will help us to shed some light on this. Any other thoughts, Kirtan, before we move on to the next, Alec? But wonderful case so far, Sammy. Very interesting.
Yeah, amazing discussion. Love hearing discuss you guys this case. You would think with a 21-year-old woman that she's healthy, right? But she has no past medical history. That was not the case with this patient. She has an extensive past medical history of secondary steroid-resistant idiopathic nephrotic syndrome. The initial diagnosis was 2014, and she received multiple kidney biopsies at that time that showed FSGS. She had multiple treatment courses of cyclosporin A, rituximab, mycophenolate mofetil, tacrolimus. 4 months ago, she had a relapse of her nephrotic syndrome, and she received rituximab 500 milligrams IV. And 10 days ago, she also received 1 gram of rituximab IV. Otherwise, she has consequently secondary humoral immunodeficiency, for which she's receiving IVIG therapy every 4 weeks. And she also had a mycoplasma pneumonia 1 year ago. For medications, she's on an ACE inhibitor. She takes trimsulfa 3 times a week as prophylaxis and toracimid as needed. For family history, her uncle also has nephrotic syndrome of unknown etiology, and another uncle has epilepsy and type 2 diabetes mellitus. For social history, she has occasional contact with a friend's dog, but states that the dog doesn't lick her and also didn't bite her recently. She is monogamous with her boyfriend, always uses protection. 1 month ago, there was a beach vacation in Italy. She never traveled outside Central Europe. She's a student, likes to walk in the forest, but does not recall any insect or tick bites. She does not drink, does not smoke, does not use any recreational drugs, and her last menstrual cycle stopped 2 weeks ago.
All right, so we were asking for more information. This is a lot of information, and this really does add many twists to the narrative of this case. And with this steroid-resistant nephrotic syndrome, so adding nephrotic syndrome, so if we start developing a problem representation, because there's so many different facets to this case. 23-year-old has adonophagia, has arthralgia, has myalgia, now has FSGS. I think the first thing we have to think about, what's commonly linked with FSGS is HIV, right? So HIV must be ruled out. And HIV, acute retroviral syndrome, although this is not acute, but HIV and impaired immune response can open up the door, Pandora's box, to many different kind of manifestations and things. And it affects almost every tissue within the body. The patient is also immunocompromised with this, what was the condition I'm looking for? But this patient receives IVIG every 4 weeks. So the patient's immune background is deficient. So she could manifest with many different infections, mainly could be viral infections. If we also think about the domain of FSGS, HIV can be common. What we call HIVAN could also manifest in this way as well. Hepatitis may also manifest in this way as well. We would have to do testing for both HBV, HCV. Parvovirus was mentioned in the chat by Dr. Snyder earlier. That would be something also that we would have to figure out, and also EBV we would look for as well. That could manifest in this manner. Could there be lupus? If we switch gears to the autoimmune world or domain, I mean, lupus we would have to work up as well and get the anti-double-stranded DNA is associated with renal disease, and also get complement factors in this case as well. Any other thoughts there, Kirtan?
Yeah, Dr. Singh, like I agree with you that there are multiple facets to this case, and we have to see that which is the facet that we want to solve now and which is most relevant, right? Because if we think about it, we are talking about a young person who is immunocompromised by the virtue of the medications that she is receiving for nephrotic syndrome of unknown etiology and possible familial component as well, and who is now presenting with acute symptoms, right? So it's completely possible that what she's having right now has got nothing to do with her nephrotic syndrome. It has got nothing to do with what is her background. It is just a complication of what she is receiving for the nephrotic syndrome, right? And that is important because in the first aliquot we were discussing, right, that when you see the rheumatologic symptoms acutely, you think exogenous, endogenous, right? And exogenous will always be way more common because what are the odds that you are completely healthy, next day you wake up, you have a rash and you're diagnosed with lupus or Still's disease? Extremely unlikely, right? But you can wake up next day and you are diagnosed with some viral infection, right? So we are thinking that can she have some viral infection? And now the fact that she has such immunocompromising condition, you might entertain those possibilities, right? And just to kind of enlist what Dr. Singh was saying, that whenever we think about acute onset viruses causing such fulminant presentation, you always worry about what we call as the IMLS, which stands for infectious mononucleosis and infectious mononucleosis like syndromes. So when we say like syndromes, it's important to understand that the EBV spectrum encompasses so many other similar viruses which can present identically. So we talked about EBV, but then you think about CMV, you think about HSV, VZV, then you think about like parvoviruses, your measles, mumps, rubella category, then you think about mycoplasma, Bartonella, HIV, all of those fall in the same category that they acutely can present with such kind of presentation, right? So you would be entertaining that, hey, should I check for at least some of them? So like HIV, hepatitis, syphilis, and parvovirus is reasonable. And you don't want to check for all other viruses because it may not change the management as such. But these viruses, they do change the management, so you can check for them, right? But what I'm worried more about is that this person is receiving rituximab, and the last dose was 1 week ago. And we were saying, right, in the first aliquot that what is the exogenous stuff which you are receiving? Is it the substance? Is it the drugs? Is it the vaccines? So rituximab is one of the monoclonal antibody. And whenever you receive the monoclonal antibody, you are at increased risk of what we call as the serum sickness, right? And serum sickness like reactions. And we know that serum sickness is basically type 3 hypersensitivity reaction, which can mimic any of the autoimmune diseases. People can present with arthralgias, they can present with rash, they can have mucosal symptoms. And if you do the labs, you will also find maybe low complements as well, right? So all of those things are possible. So I would be curious that when we examine this patient, are we eliciting the arthralgia and not arthritis? And the rash is maybe, let's say, maculopapular in nature, maybe morbilliform, and eventually the lab shows low complements, then it would be a very good story for serum sickness, right? But as Dr. Singh said, that we have to do our due diligence. So at least checking for the must not miss viruses and like STIs is important. So we will take care of that. So that is the one aspect of this case that I'm trying to figure out what is going on right now, right? But then if you look like the background of this person, and we are still not sure where the case will head, right? That is Sammy presenting the case in a way that at the end we will have to figure out where is this nephrotic syndrome coming from or not? Or is it just going to be one of those things that you have nephrotic syndrome, you never figured out, but we are dealing with what is happening right now, right? So we will see how the case evolves. But the big picture for FSGS, like pathophysiologically speaking, I will just highlight that FSGS basically represents a form of podocyte injury. And if you think about your glomerular membrane, the reason why you are able to resist the protein leak is because of the podocyte and the slit diaphragm that it creates. And whenever there is a damage to the level of this slit diaphragm, that is when you get FSGS. So FSGS is by definition podocytopathy, the another important one being minimal change disease, right? And FSGS can have so many different causes. FSGS can actually represent the end form of histological pattern from a variety of inserts. So you can have something as simple as, let's say, sickle cell. You can be something as simple as just obesity. And at the end spectrum, you can end up getting FSGS because of the way the kidney responds to that injury. But the age of this person is very striking, that all those secondary adaptive causes of FSGS from the hemodynamic and metabolic insults in the body takes time to accrue. So if obesity is causing FSGS, you need to be obese for like certain number of years. But if you are getting FSGS so fast, then you are tempted to think that is it one of the genetic or autoimmune etiologies? And we won't enlist all of them, but it's important to understand that when podocytes are functioning in that way, what are the important genes which play a crucial role in making sure that podocytes are anchored there in the right position, and we will have to think about those genes. And then finally, what are the autoantibodies that you can have against those podocyte antigens? And there are so many of the autoantibodies which can cause podocyte damage, and we will entertain that possibility later on if the case goes in that way. So that was what I was thinking. Dr. Singh, any other thoughts?
No, just the fact that, yeah, this patient has been determined to have severe immunosuppression from multiple angles. I think with this, going back to this organophagia, while you were talking, yeah, I think I'll be very interested in viral and fungal esophagitis. Could there be multiple things going on with this patient? Patient's immunocompromised, has one condition, and is immunocompromised opening the door to infections. Not sure yet, but what I do want to know in the exam, first vital signs, does this patient have fever? Does this patient have neutropenia? Does this patient have hypotension? And then the examination of the head and neck areas. So I'll be very interested in these findings. Any other thoughts before we turn the mic over to Sammy?
Let's see.
All right, Sammy, take it away.
Amazing discussion. All right. When I saw her in the emergency department, it was 2 a.m. in the morning. So gotta stay focused at that time too. Her temperature was 36 degrees Celsius, so no fever. Her heart rate was 89 degrees Celsius, 89 per minute, I'm sorry. Blood pressure was 115/70. Her respiratory rate was 16 per minute, and her oxygenation on room air was 99%. She was awake, fully oriented, was in reduced general condition, had a normal nutritional status. So mild distress, I would say. For her hint exam, which we are all awaiting, right? Her conjunctiva were anecteric. I looked into her pharynx and I saw some erythema, and the tonsils had slight whitish exudate. And she really said that she couldn't open her mouth too much. She said only like 2 centimeters, maybe something like that. She was only able to open her mouth 2 centimeters. I also checked for cervical lymphadenopathy. There was bilateral cervical lymphadenopathy around 1 centimeter, painful to touch, not fixated. The neck was otherwise unremarkable, no masses, no meningism, and the trachea was midline. Otherwise, cardiovascular, pulmonary, abdominal exam were unremarkable. Now to the musculoskeletal exam, she had mild tenderness to palpation of the wrists and finger joints, especially the MCPs and the PIPs. There was no swelling or erythema. And for the skin, there was a fine maculopapular rash in the trunk and also the upper extremities. There were no signs of peripheral emboli and no lower extremity edema. What do you think?
Wow. So rich examination, and at least the part which I am comfortable with is that patient is looking stable. Why this is important? Because think about such presentation, but you're entertaining the bacteria. That, oh, maybe this person has active staph and strep infection, and maybe they have like toxic shock syndrome, which is causing this rash. You would expect them to be febrile, you would expect them to be hypotensive or tachycardic. Not to say that it cannot develop, maybe you are catching it so early on, but it's the flavor which we are getting is more of like not the classic bacteria. It probably is viral or maybe atypical bacteria, but not the classic gram positive, gram negatives, right? And which is important because it can guide us that should I give this patient vancomycin, ceftriaxone right now, or do I have a time to breathe and try to understand the problem, right? So in this case, looks like that firstly, patient doesn't have a cough. And what we saw is that patient has bilateral tonsillar exudates so severe that you are getting trismus as well. Pharyngeal erythema, non-specific, right? But the main frame which I was thinking was that what Dr. Singh was saying, that should we at least think that does this person have group A strap and should we check for that or not? So very reasonable, we should check for group A strap, but the overall picture maybe sounds more like the viral etiology, right? Now in young person, whenever you are dealing with a pharyngeal syndrome, again is the same as where we started, that is it something exogenous or is it something endogenous? So in the exogenous category, the most important would be the STIs. And you should think about all the possible STIs based on the mode of acquisition, right? So not just HIV, hepatitis, and syphilis, but also think about chlamydia, gonorrhea, monkeypox, and all other pox group of viruses, right? So it's reasonable to entertain all of them. and get the mucosal swabs for each and every one of those infections, gonorrhea, chlamydia, monkeypox as well, apart from serological evaluation for HIV, hepatitis, and syphilis. Apart from that, what about the non-STI viruses? So that what Dr. Singh initially said, and we discussed about IMLS, right? So you should think about those viruses. And in particular, given the articular manifestations, you would be inclined to at least check for parvovirus more so than any other viruses, right? Let's say if we do the thorough viral evaluation and if it is negative, and if this is an endogenous syndrome, then we are dealing with a unique space because there are not many diseases which can come this fast and can end up affecting your articular structures and cause maculopapular rash, right? Given the base rate, you should entertain lupus for sure, SLE. And often SLE travels with a similar disease known as Kikuchi disease. And we know that Kikuchi disease is classically known to cause cervical lymphadenitis. It can cause variety of musculoskeletal symptoms. So one might be inclined to think that should we consider the possibility of Kikuchi disease along with the SLE or not, right? Similarly, when you have articular manifestations, you also wonder about the innate immune system and you start thinking that could this be one of the hereditary periodic fever syndromes? And if it's not hereditary, then could it be the adult onset variant of it? And that classic example being the our like Still's disease, right? If this person had been exposed to COVID, let's say, then we know that COVID infection is known to trigger a kind of autoinflammatory syndrome, which sometimes looks like Kawasaki disease, which is also known as MISA, like multi-inflammatory syndrome of adulthood. So in this person, let's say if COVID turns out to be positive, or if we come to know that patient had been exposed to COVID few months ago, then you start entertaining that hypothesis that, okay, could this be MISA kind of pathogenesis, right? Now, these are the common autoimmune diseases which can come from endogenous. What else can come from inside the body is the more sinister, what we call as the lymphoproliferative diseases presenting acutely. So oftentimes on our own VMRs, we have seen that people can have, let's say, certain unique kind of lymphomas, classically the T cell lymphomas and Hodgkin's lymphomas, and some kind of lymphoproliferative diseases, like kind of like Castleman's disease, which are known to cause aberrant immune activation, which can mimic the rheumatologic disorders and which can present acutely and permanently as well. So this person's CBC will be very illuminative. Like if we see, let's say, profound pancytopenia, and if we see the blast on the peripheral smear, it's a different story, right? If we see that this person's LDH is like 600 and the patient don't just have cervical lymphadenopathy, but lymphadenopathy is everywhere on the CAT scans, then you again start thinking that, okay, something is really wrong. Maybe this person has probably some kind of lymphoma, right? So I think I'm still trying to juggle all the possibilities, starting from the most common and must not miss from like viral infections, STIs, and then going to the endogenous autoimmunity, and finally to the rare lymphoproliferative diseases. What do you think, Dr. Singh?
Yeah, Kirtan, yeah, great. I think the findings of the head and neck are quite remarkable. I think we can then focus in, like you said, the lymph nodes. I mean, the tonsils are definitely in focus here, right? So infection, you can't help but think infection, but they're very uncommon. But you know, this being VMR, you have to sort of think behind infection. So a testing panel will be very, very helpful to at least work through parvovirus, EBV, CMV, group A strep, and so on. If none of those are positive, and those can actually manifest with a multi-system sort of presentation like this, if they aren't found to be positive, then we need to pivot to the other sort of conditions that can occupy the space of the lymph nodes, namely, like you mentioned, lymphomas, and then also some of these rare lymphoproliferative conditions. I think we'll start off with some labs to see that really will help. So if the white count is high, we definitely need a differential to see the proportion of cells that are making up the white cell. And I kind of feel like at some point this might lead to a biopsy in this area, but it may be premature if there is a lymph node. I don't know. Imaging will be helpful to see in this case. But yeah, I mean, epidemiologically, this patient, it can have any number of these different conditions. But let's not jump the gun. Let's start off with the CBC and chemistry. Over to you, Sammy.
All right, you asked and you shall receive. So her white blood cell count was 15.5, neutrophil predominant. There were 13.4 thousand neutrophils, 0.9 lymphocytes, so lymphopenia. There were no eosinophilia, and the rest of the differential was within normal limits. Hemoglobin was 15.4, platelets 166,000. COVID, influenza, RSV swab, strep throat were all negative. Her CRP came back mildly elevated at 15, upper limit of normal being 5. Her urine dipstick showed 3 plus protein, but was otherwise unremarkable. No blood or anything else on the urine dipstick. Otherwise, her creatinine, electrolytes, liver enzymes, glucose, coagulation were all unremarkable. ECG showed normal sinus rhythm. I did a chest X-ray. There were no infiltrates, no signs of congestion, no osseous abnormalities. Then I reached to the POCUS and was thinking maybe she has Lemierre's disease, right? I wouldn't want to be fooled by that. So I checked her jugular veins. There were no thrombosis there. There was no thrombosis there. I was also concerned for some kind of abscess. There was no soft tissue swelling, no expansion, only the reactive lymphadenopathy that we already felt, and the thyroid looked also normal, no hypervascularization, not painful to touch. What do you think?
Absolutely wonderful presentation so far, Sammy. You delivered each aliquot perfectly. You have not lost your touch. A fantastic case. I absolutely don't know. I don't know what's going on. I sort of have this Rapunchu has put all of the thoughts given nicely into a 3-bucket approach. I think that's pretty much the space that we're occupying in regards to our approach to this. I think if you look at the hematology by itself, it's not uncommon. Just with this, you may reflex to starting antibiotics because we do see a lot of streptococcal pharyngitis, and may not be a bad idea to maybe initiate antibiotics and see if there's a response to this. So the white cell count is elevated, neutrophil are elevated, and when neutrophils go up, they will go up at the expense of the lymphocytes. So the lymphocytes will be diminished in this case. And just looking at the chemistry pattern, sometimes you'll see with some of the other viruses, you may see some signal or pattern that may evolve. So here you're looking for if there's any elevation in the liver enzymes, which we're not seeing here. The UA it goes along with the nephrotic syndrome that we see, and the strep and RSV is negative. I have come across situations, strep could be there is a percentage where it could be false negative. You may repeat in a few days and then get a good sample, or it's just like if the sample is obtained in a proper fashion. So at this point, this is signaling could possibly be bacterial infection. Early viral infection could be a play here because initially the neutrophils go up. Then you see a shift over to increase in lymphocytes. If I remember the monospot tests, if we're thinking with rituximab, won't be positive with, say, CMV, EBV in this case. That's a great thought about Lemierre syndrome, just in case, like one of the emergencies. So just to get a focus and make sure that's not a play. But I think to push the diagnostic needle forward, we will need to do more testing here, because right now what this has given us is not much really to work on. I mean, we do need to do a few more test viral panel to make sure we're not dealing with any of these CMV, EBV, and so on. Any thoughts, Kirtan, at this point?
Yeah, no, Dr. Singh, I agree that we still don't have certainty as to which bucket we might be entertaining more, and probably what we need is more data. So far, all we know is that there is neutrophilic leukocytosis, and as we were saying, like lymphopenia, like one might entertain that, okay, could it represent certain unique viral infections causing bone marrow suppression? But in acute setting, often it's hard to make that judgment, and you just have to go with the flow. Like you will look for HIV no matter what, right? Even if there's no lymphopenia, you are going to check for it, right? But I'm not putting too much weight on lymphopenia yet because it's not a prominent part of our equation yet. One important caveat which I would mention regarding all the labs which you are seeing right now is that it's a snapshot, right? It's like you can have variations in that within 5 hours. So I think it's very important to check the trends. Like it is perfectly possible that platelets are like on the lower side. If you think about it, in general, in inflammatory states, you should expect these platelets to be maybe even on the higher end, maybe 200, 250, 300. What we are seeing is 166, right at the cusp of being thrombocytopenic. So who knows if we recheck the labs maybe 2 days from now and patient has florid pancytopenia, and then you will suddenly start thinking about the whole other bucket, whole other domain of infections, right? So I think we will see what Sammy tells us about the trend of the labs. And maybe the liver function is good now, but it might be going towards like transaminitis maybe in few days from now. So we will take that. And another important point I want to know is that whenever you are dealing with a disease, you wanna define the extent of the disease before you try to explore the disease. So far, we are thinking that the disease is localized in the head and neck region and over to the skin and the articular structures. But has it affected the viscera yet? How we will figure that out? Either we have the signature based on the labs, like if this person has evidence of pancytopenia, then you think that maybe bone marrow is implicated. If this patient has evidence of coagulopathy, then you start wondering that could this be DIC kind of pattern, right? If this person has liver failure, then you think liver is impacted. If they have hypoxia, then you start wondering that, okay, maybe they have signature in the lungs. So we need to define the extent, and we still don't know the extent yet. Why we don't know the extent yet? Because the diseases can hide without leaving a signature on the labs, especially in the initial phase. So we know this person has cervical lymphadenopathy. We don't know if they have hepatosplenomegaly. We don't know if they have mesenteric lymphadenopathy, and we don't know if they have thoracic lymphadenopathy, right? And X-rays are not going to help you. So what I'm wondering is that since this is a young person who is immunocompromised, and we don't have like a clear like diagnosis, which is our like if this person had like florid strep throat positive, you treat them, they get better, sure, you don't need to do anything else. But in such host with rituximab on board, you should get the CAT scans. So I would be more interested in defining the extent of the disease and getting the CT chest abdomen pelvis with IV contrast. And once we know the length, like lay of the disease, then we can start to explore the buckets more closely. What do you think, Dr. Singh? Any other thoughts before we go to Sammy?
Oh, absolutely wonderful. Yeah, it's funny. In the war against disease, the fog of war is quite thick. It's very difficult to see beyond what we just see here. But you're right. Every patient is on their journey, and during that journey, time is a great unmasker, or it will unmask what is truly going on. And like you mentioned, this patient may just flip the switch, and something may just come up, which may help us to pivot to the diagnosis. So it's quite difficult because you sometimes you're out of your depths. But I think, yeah, if you're thinking about lymph nodes here, how about lymph nodes internally? That was a great reflection. I really like what you mentioned. Yeah, maybe that we have a low threshold to image and see if there's like a lot of like connected lymph nodes. And if you think about it, lymphomas, again, going back to the age range, certain lymphomas will start in the head and neck region and then spread downward. So lymphoma is something that could still be a play here. So yeah, I love that. I would have a low threshold for getting imaging in addition to further lab testing. Over to you, Sammy.
Yeah, it's so interesting to hear your thoughts. I was thinking the same, and then I was also thinking she's 21, and I was talking to her about getting a CT, and she was with her mom, and they were like, no, no radiation. I was like, okay, whatever you want. I gave her some IV Tylenol, and she basically did much better. And she was like, I want to go home. I want to try outpatient management. So I said, okay, if you 100% want that, I was thinking she has most likely an upper respiratory tract infection. And she was, yeah, I also think the same. And I want to try to go home and see what happens. And I will go to my primary care physician the next day to get labs. And so I wrote a prescription, I sent her home, and I went home after the shift and I came in the next day and I was on the ID consult service at that time doing my rotation and I was checking into consults and suddenly her name pops up. And then I was like, oh, I need to see her again. And then I was looking into the chart and 6 hours later, as Kirtan predicted, she came back. And because the joint pains got much worse, all her joints were severely painful. The Tylenol did not help. Also, the other NSAID that I prescribed her, low dose, did not help. So she got admitted to the nephrology ward. So when she was readmitted to the ward, her vitals were basically unchanged, but her heart rate was now 124. I went to see her for the consult, and she had now diffuse tenderness of nearly all joints with marked limitation of range of motion. She was unable to lift her arms due to pain, but there was no swelling and no erythema. And she again said, I can't open my mouth properly. And she was only able to open her mouth for 2 centimeters, same as last time. Her skin, she still had this fine maculopapular rash on the trunk and upper extremities, and I checked her labs. Her leukocytes went from 15 to 16.2, and her CRP went from 15 to 400. So within 24 hours, exploded the CRP. The rest of the labs were without change. The platelets remained normal. The liver, renal function remained normal. Blood cultures were drawn in the ED. She was started on piperacillin tazobactam, and I reordered a procalcitonin from during the night. It was normal when I saw her in the emergency department, but 24 hours later, the procalcitonin was 9.3. And she has had so debilitating pain that she now required IV low dose opiates due to refractory joint pain. What do you think?
And I think, Semi, thank you for painting the picture for us. And before I start discussing, maybe one clarifying point. Right? Do we know the ferritin, if we got it yet? Ferritin and LDH?
LDH was, I think, I don't have it, but I think it was around 300. The ferritin, I need to check. I will let you know in the next aliquot.
Okay, perfect. Thank you. Dr. Singh, I forgot. Was it your turn or my turn?
I think I forgot to. I don't know.
Yeah. It's fine. I can go ahead and maybe
Go ahead,
then
yeah.
you can fill in. Yeah. So looks like that we were worried about this patient, right? That young lady, immunocompromised, fulminant symptoms. We still don't have a catch on what exactly it could be. And we gave some conservative management. We sent patient home, but unfortunately she came back again. And what has changed so far? In the vitals, all we know is she's tachycardic. Now, tachycardia, like give fluids, control their pain. But what I'm more worried about is, could this be more than that, right? So you should still get EKG, and we will see. Like, the only reason why one might get EKG in this situation is that if it shows something else than sinus tachycardia, maybe like, let's say premature atrial complexes once in a while, maybe some atrial rhythms, or maybe you get the EKG and it shows some ST segment changes, then you might wonder that, okay, does this person have some element of myopericarditis? Because we know that all these viral infections, all the autoimmune diseases which we talked about in acute setting can affect your myopericardium and can end up causing some arrhythmias, tachycardia and stuff. So that is the importance of getting the EKG and importance of like understanding that what kind of rhythm is this, right? Perfect. Apart from that, patient is fortunately doing good. She's not unstable. She's still not like febrile, right? And her examination hasn't changed dramatically in terms of objective findings. All we know is that she has more tenderness everywhere, but the rash has not progressed. We haven't heard that she has more mucosal involvement as such. The trismus she always had, which is now present as well, and are probably even more worse, right? So where should we go from here? So again, we are back to square one, that we don't understand the problem, right? So we still want to get the viral studies, which like we wanted from the get-go, right? That at least like the HIV, syphilis, hepatitis, and then the extended like EBV, CMV, parvovirus, and then like your other IMLS stuff, which you talked about, like mycoplasma, toxoplasma, Bartonella. We need to take care of all of that, right? Now that we have reached to that point where things are not making sense, we can also entertain the rare possibilities, right? So we did say that what else can you acquire from the mucosa? So we said that you need to look for all the STIs, but then certain unique zoonotic infections, you might wonder at some point in time. So the three classic infections that we must not miss. So one of them is leptospira, second is Yersinia, and third is tularemia. Because all these three infections, if you acquire through the mucosa, through the oral cavity, it can cause fulminant inflammation in the head and neck region. And then that inflammation can seep down into your mediastinum and you get like what we call as the hemorrhagic mediastinitis, right? And it can be fulminant, fatal, and very hard to figure out, right? And especially when you are on rituximab, like even the serologist may be falsely negative for those like infections, and you might need PCR and advanced testing, right? So at the back of my mind, now that we are near the end of the case, I'm also thinking of, apart from the common viruses and IMLS group of organisms, could this be rare zoonotic infections as well? And do we need to expand our net and check for all of them, right? Second thing, very important, would be to get the ANA with double-stranded DNA and complement levels, because that will tell us a lot. If ANA double-stranded DNA is fluoridly positive, then suddenly you will like forget about all the infections. This likely seems like lupus, right? If ANA double-stranded DNA is negative, but complements are profoundly low, both of them, C3, C4, then suddenly you start thinking that it's reasonable that we did infectious workup, but maybe this could be serum sickness, right? So that's why those ANA and C3C4 will be very instrumental to make more progress. And now that she is worsening, we will get the CAT scan, obviously. But now I will also want to make sure that we look at the neck very closely. That this person has trismus. Is it just from the tonsillar inflammation? And our job is to find out why tonsils are inflamed, or is it something else which is complicating in the head and neck region? And CT neck can tell us if there is something wrong with the mandible, something wrong with the muscles of the mastication, if there is an abscess there or some kind of fat standing there, and which can guide our differential further. So that is what I will do. CT, neck, chest, abdomen, pelvis, and all those serologists which we talked about, and getting the complements that will help us a lot. What do you think, Dr. Singh?
Yeah, I think we're still revolving around these hypotheses. You know, it's funny, I really haven't gained traction with this new data. I mean, obviously the patient is sick, right? She's the person that look fine. We have many of these patients, they come to the emergency room, they look good, they get sent home. There was recently a story in New York City where a college student was sent home and ultimately sepsis was missed. I don't think this patient is in sepsis, although they're immunocompromised, so they could be very atypicals. But these were patients I do worry about because the fever, if they're immunosuppressed, especially with rituximab on board, hypogammaglobulinemia, they're not going to have fever. And these are the patients that actually deteriorate very quickly and can mask really severe infections. What I think at this point, I think I really like that hypothesis of serum sickness. I think with the SED rate being elevated, SED rate was pretty high, 124 here. Complement will be interesting. You mentioned complement. I would like a complement. That also would be low in serum sickness, and that could manifest with this. You know what's interesting? I kind of eyeballed the rest of the data, and there's so much to entertain, but recent dog exposure. Why did Sammy mention to us recent dog exposure? Am I going down a very deep or a rabbit hole that just leads to nowhere? I don't know, but I may visit dogs. Okay, what can dogs bring us? If there's a bite, could there be, rabies in the mouth and all that? You see, I don't think rabies is a play here, but it's just interesting to think about. You also talked about tularemia. I don't think dogs have that, but if you have a dog bite, you get that capnocytophagia. It wouldn't manifest in this manner, especially with rash and everything. Dogs can carry ticks, so tick-borne disease could affect the joints, but I don't think, I mean, you could get rashes in this manner. So the dog, if you do overlap that into this problem representation of 23-year-old with the rash, muscle pain, joint pain, and then having no fever, immunocompromised, white count, now tachycardia, and this maculopapular rash. I don't know when this maculopapular rash, could it be a manifestation of the drugs? I mean, I was thinking about, could this be a DRESS syndrome or something devastating like that? None of these drugs, I don't think, would trigger something like DRESS, and I don't think the head and neck and the odonophagia would happen because of that. So still a lot of hypotheses at play here. And I would like the CAT scan, though. I think let's kind of look internally to the patient, right? What will kind of help us shed light? If the CAT scan is negative, then we're good. Then we're good, right? So we go back to the head and neck. If the CAT scan is full of lymphadenopathy, then we can start working on that, I would say. Yeah. Okay. Back to you, Sammy.
Yeah, amazing discussion. I love hearing your thoughts. Kirtan, I looked the ferritin up. It was 250. Okay, so HIV, hepatitis, Legionella, pneumococcus, urine antigen, all negative. HIV, hepatitis, obviously serology. The albumin creatinine ratio was 4.6, so markedly elevated. The protein creatinine ratio was 5.1. Alpha 1, beta 2 microglobulin was slightly elevated, consisted with tubular injury. Microscopy only showed Malteser crosses, consisted with nephrotic range proteinuria, but otherwise no signs of glomerulonephritis. Her CD19 cells were 59, which is decreased. Normal is 100 to 415. Her ANA, ENA, ANCAs, rheumatoid factors, anti-CCP were all negative. Her IgA was 0.1, upper limit of normal being 0.7, so decreased. IgG was 5.7, also mildly decreased with an upper limit of normal of 7. IgM was 1.4 within normal limits. Free light chains were unremarkable. There were PCRs drawn from the blood, adenovirus, CMV, EBV, HSV, VZV, parvo P19, HHV6, all negative. PCR throat swab was rhinovirus positive, and she had mycoplasma and adenovirus also negative. Her abdominal ultrasound was unremarkable, no signs of splenomegaly, no lymphadenopathy, and we did also a formal TTE on her. There were basically also no signs of endocarditis. So there was not a CT performed, like her symptoms in her mouth remained stable. That was most likely due to a rhinovirus, the treating physicians were thinking. And then when I went to see her, she mentioned that she had 3 similar episodes of polyarthralgia, rash, and occasional fever, each occurring 6 to 10 days after rituximab administration. I ordered complements. Her C3C was 1, which is at the lower limit of normal. Lower limit of normal is 0.9, and C4 is 0.07, which is mildly decreased. Lower limit of normal is 0.1. And with that, I propose the treatment.
Wow, amazing. We got the compliments. Just the linking of those symptoms around the administration of rituximab, I think it really does help us understand what we're likely dealing with. So yeah, serum sickness, because you know what's interesting, like though with the hypogammaglobulinemia, you need an immune response to trigger this. So is it going to be as devastating? Because this is a very devastating presentation if you think about it. Very sick. So this hypogammaglobulinemia, but maybe the response would be worse if she was immunocompetent, but you can still have this condition. But just the fact that the complements are so low, I think it does correlate with what I mentioned earlier with the serum sickness, type 3 sensitivity reaction. Any thoughts, Ketan?
Right, Dr. Singh. Perfect. So I think Sammy has left us at the right cliffhanger, right? That this person presented initially, got some conservative management, came back again because patient is not improving. But then, as we said, that why patient is not improving or what is going on, patient hemodynamically is stable, right? Like patient looks great, like it looks great as in like there's no organ dysfunction which we could glean into. All we see is that she feels very sick, so much pain, so much mucocutaneous stuff going on, but nothing in the like your viscera, like LDH just mildly abnormal, ferritin completely fine. Think about the inflammatory syndromes and ferritin levels. When was the last time you saw ferritin of like 300 without any obvious like iron deficiency or something, and still you are not mounting the response, right? So kind of tells you that whatever we are dealing with is in a way looking very fulminant, but probably is not causing too much excavation inside your body, right? Not like catastrophically destroying your organs. Kidney seems to be doing at baseline, liver is fine, lungs are fine, heart seems to be doing okay as well, right? Now, what are the hypotheses which are still remaining? So looks like that all the viruses and all the atypical bacteria which we wanted has been conclusively ruled out. Of course, one can entertain the possibility of, like, as we said initially, zoonotic infections, but we don't have the pretty significant signal yet, right? Then you start wondering that could it still be one of the bacteria which has not grown in the cultures? We were saying initially that this would be a little bit atypical for the classic gram-positive, gram-negative bacteria because of the fact that patient is still hemodynamically stable, nothing has grown in the cultures, and patient did receive piperacillin tazobactam, which is it may not cover all the atypicals, but it does cover the classic organisms, right? And why I bring up the classic organisms once more, despite the clinical picture not being consistent, is because of the fact that patient has hypogammaglobulinemia, low complements, and nephrotic syndrome. Now, very important to understand that people with nephrotic syndrome can have low complements if the nephrotic syndrome is significant enough, because when you are losing the proteins in your urine, you lose every single kind of protein. So you lose the complements as well. That is why sometimes nephrotic syndrome causes acquired hypocomplementemia, right? So that is why in such scenarios, often the baseline complement levels are very helpful, right? That if patient's baseline complement levels is something and then there is a decline in that, then you can understand there is a superimposed process going on, right? Now, why complement levels are important in this scenario? Because think about what infections you get when the complements are not functioning. right? So you think about the encapsulated organisms classically. So meningococci, gonococci, strep pneumonia, Haemophilus influenza, the four classic bacteria. And then in the atypical bacteria, you think about Babesia and Capnocytophaga, right? So Sammy has told us that I think one of those, like meningococcemia PCR, was negative. And we should still work up nothing has grown in the blood culture, so you can't do much. And I assume when the PCR of the SAB was done, it would have captured Haemophilus influenza or strep pneumonia if it was meant to be. But we can still wait for the blood cultures to see if any of those grew up, right? Nothing in the peripheral blood smear, no classic exposure, so not worried about babesia. Capnocytophaga, Dr. Singh brought up, is a fair hypothesis, but just doesn't seem like classic, like tonsillar inflammation, not very classic for that, right? And maybe tonsillar inflammation was from rhinovirus itself. So first priority, get those blood cultures, make sure you're not missing that. But once you move past that, not much is remaining. The fact that Sammy's team didn't have the CAT scans means that answer is not in the CAT scan, right? Like this is not going to be a Castleman disease or lymphoma because we don't have CAT scan, right? You can't get those things without that. So doesn't look like Still's disease, HLH pathology because you don't have high ferritin. ANA is negative, so lupus is out as well. So having exhausted all this, then the mind comes to like what we're initially saying, is this serum sickness and the fact that patient has had prior episodes and there is profound polyarthralgia there. She has seen rash as well in the past. And the compliments, we will clarify with Sammy eventually that was it lower than her own baseline or not, which could really pull the trigger towards the serum sickness. And also if you think about the management wise, that this person has received antibiotics, has received fluids, has received like antipyretics, but what patient has not received? Patient has not received steroids, right? So is it the case of steroid deficiency, right? Like, is Sammy going to say that, oh, I started patient on prednisone 60 milligrams, and then within 5 hours, the patient's joint pain went away? Then we have an answer, right? So I think that is where I'm gravitating right now. Get the blood cultures and everything, and then see the baseline complements, and then give the steroids. What do you think, Dr. Singh?
Absolutely, yeah. It seems very much like serum sickness. It can cause the lymphadenopathy, the fever, the rash, the joint pains. It can be very, like you said, it's not devastating, but it's very debilitating, which it seems to be with this patient. And you know what's interesting? The patient went back and came back, and anytime somebody comes back with a very dangerous condition, bacterial infection and so on, they come back, they could be in septic shock. You allow that immune dysregulation to ramp up and the vasculature destruction that happened, the glycocalyx destruction and edema and so on. So if it was a bacterial infection, this patient would come back probably seriously ill, but she's coming back with the same sort of manifestations. So it's a cycle of this condition that keeps happening, but she's not any worse. So very interesting. These compliments, I don't know. I don't usually dabble with the levels, but they seem very low to me. But I think Sammy will shed some light on that. Back to you, Sammy.
Yeah, I love listening to you guys, and I know now I notice how much more I missed you. Yeah, so to Kirtan's point, the blood cultures were drawn before the empiric antibiotics, and obviously there wasn't there was no growth in the blood cultures. When she was at the ward, she had some daily fever spikes despite the antibiotics, and also her inflammatory markers continued to rise with the piperacillin tazobactam. The complements were always normal, but when we drew this lab, the C4 was mildly decreased. So as you can see, not that decreased. So what we were thinking was also rituximab-induced serum sickness, abbreviated RIS, and she received 50 milligrams of prednisolone, and I swear 4 hours later, she had no symptoms. She had not a symptom at all. There was no polyarthralgia. She could open her mouth. She had no fevers. Her CRP in 20 hours later was like halved. It was insane to watch. I've never seen, that was my first serum sickness that I ever saw. And it was just so incredible how fast she responded to the steroids. Yes, she was discharged after 3 days and scheduled for outpatient follow-up in a nephrology clinic. And when she came back, her albuminuria had completely resolved. So the rituximab did its job, luckily, but it also caused this marked symptom complex. So we sent antibodies to rituximab. You can do that. We sent it to the Netherlands to a lab. and it came back markedly elevated. The rituximab IgG with a level of 210, normally is less than 30. So the nephrologists were thinking we can't start it again with this fulminant reaction. So she got started on obinutuzumab. That's a fully humanized anti-CD20 monoclonal antibody without the potential for the development of serum sickness. And currently she's on obinutuzumab and doing very well without albuminuria. And I wanted to present you this case because I found it very fascinating. And one interesting fact that I learned about serum sickness is the classical triad that we all learned: the fever, the rash, and the polyarthralgia. You hardly ever have arthritis. It was quite impressive. I mean, I was expecting that from Kirtan, to be honest, after knowing him that long time, that he said no arthritis, but mostly arthralgia. And I was thinking, why is she not being able to open her mouth? The lymphadenopathy was not that extensive. And then I found out that serum sickness causes TMJ, marked arthralgia. So she really had this TMJ arthralgia. I didn't palpate it because I obviously didn't know it. But I think that explains also why she wasn't able to open her mouth, because the lymphadenopathy really wasn't so extensive. So thank you all for discussing and having me.
Perfect. Thank you, Sammy. You came back and you came with a bang. You taught us so much from this case, like how the workup progress is, how did the patient do. So thank you so much. And I always wonder that what would world be like without prednisone and ceftriaxone? Like two main like drugs in our human history without which we can't survive, right? Like you give that two and maybe 50% of people will be fine, right? So glad to see that how we did the streamlined workup. And also wanted to highlight the Sammy's point in the end, like obinutuzumab is one of those antibodies which doesn't trigger the antigen dependent cellular cytotoxicity. So it causes less of these cytokine reactions. And it's actually better than rituximab. It causes like more deep and more potent depletion of the B cells. So it works better. So I'm glad that probably serum sickness happened for the good in this patient, because we gave obinutuzumab, which is now better. In the future, she would be freed from this polyarthralgia attacks, right? Poor lady. And now probably her nephrotic syndrome will be in good control. So thank you so much, Sammy, for this case. And Dr. Singh, any highlights?
Oh no, I learned a lot. I think Sammy brought such an educational case. If I was to come across this now, my patient would be diagnosed thanks to Sammy. So the downstream effect of the education that you're just permeating through this is just remarkable. Great to see you again. Please do come back and please do educate us further. We miss you a lot, Sammy.
Thank you so much, Sammy and Dr. Singh. Thank you, Sarah, for scribing so much data efficiently. And now passing the mic to Eugene to take us home with the teaching points.
Yeah, thank you so much, Dr. Kirtan. Thank you so much, Dr. Ravi, and then Sammy for this wonderful presentation. So we have a 21-year-old young patient who came with symptoms of polyarthralgia, myalgia, and rash, and then also complained of difficulty swallowing, throat pain. And if we try to look at the summary of the progress of this case, this patient was given Tylenol for supposed upper respiratory tract infection, but then went home and then came back with worsening pain. And when you have a young patient just coming with this generalized arthralgia, myalgia, rash, you're wondering, is this as a result of some particular exogenous cause or endogenous cause? So young patients typically are supposed to be healthy. So is it from bad genes, bad luck, or just bad habits? And so the exogenous causes, you're wondering if it's from viruses, drugs, bacterial infection, or the endogenous causes as a result of something going on within the body. So the body's overproducing particular immune reactions, so autoimmune. Or you could also wonder if it's some form of rare malignancy, lymphoproliferative disorder. So we also look at odynophagia, that's the painful swallowing, that they could be from an esophageal cause or structures surrounding the esophagus or even within the oral cavity. And so the next thing that we're supposed to do is to focus on the background. So what's in the background of this patient may correlate with either bad genes or bad lack of bad habits. So we realized that this patient was already immunocompromised, had some idiopathic nephrotic syndrome, and then was on rituximab, so was immunosuppressed. So we began thinking outside the box concerning various conditions, so still at the exogenous and then endogenous causes, various etiology that can hit this patient in an immunocompromised state. So back to the exogenous cause, some viruses that we considered were the parvovirus, B19, CMV, EBV, HIV, Hep B. We also considered some bacterial infections, strep A, so both the group gram-positive, gram-negative bacteria can do this. And then we also considered the endogenous causes, so autoimmune. So we're going to think about focusing on certain areas in the laboratory that can pick out whether there's SLE, Still's disease, Kikuchi disease. And then we also considered drug as part of the exogenous cause. So could it be that this patient taking some particular medicine is leading to a reaction that is bringing this particular presentation? And so we did all sort of labs, interpreted them, realized that the CBC, which showed the picture of elevated white cell counts with lymphopenia, was not enough without other pointers, like when we did the bacterial cultures PCR to pin on infectious etiology. We also realized that doing ion studies, that's ferritin, LDH, we couldn't really point to some form of visceral condition. So we wouldn't get the malignant picture, that's the rare form. And then we also try to see if there are other etiology that could be pinned to this particular condition. So we did our various viral PCRs and we realized that none were positive. So we then looked at the initial thought process, which was, could it be a drug that is causing a particular reaction? So already we had mentioned the rituximab, which is chimeric monoclonal antibody. That means it has two different forms of areas that was extracted for. One form, that's the mouse form, could actually lead to the body can produce antibodies to fight against that particular mouse form. So that could lead to the type 3 hypersensitivity reaction, which we call the serum sickness. And that happened to be this particular patient's presentation, which can present with pharyngeal erythema, tonsils, with exudates, myalgias, rash. And another fun fact that was mentioned by Sammy is that it can actually cause the temporomandibular joint pain. So if you had picked that area, that could have also influenced. So yeah, a young patient who presented with serum sickness from rituximab, and we had a pack learning of trying to rule out infectious etiology, trying to rule out autoimmune, and then also rare forms like lymphoproliferative disorders. So that's what I'll put my teaching points. Thank you.
Amazing job, Professor Eugene. Thank you. You just expanded so much on these teaching points that you have there. It's remarkably well presented. Thank you, Keaton, for co-discussing again. And again, Sammy, great job, great case. I will never forget this condition because of you. Thank you, Sarah, also Eugene as well, for help with describing and the teaching points. Take care, everybody. Have a great rest of your Tuesday. Bye.